Chair and this chairperson for today's session, and I'd like to welcome the audience as well as everybody to this third episode in the series of HIFU webinars. And today's topic will be on treatment for vulva and cervical diseases and its new options. So before we go further, I would like to first introduce our co-chair for the day, who is Professor Felix Wong. Professor Felix Wong, actually, he does not need much introduction in that regard. It is a very well-known person. He's an adjunct professor of the University of New South Wales, and he's also the chairman of CA Amigo, as well as foundation chairman of China-Australia Asia Pacific Forum of Minimally Invasive Surgery. He is very well known for his contribution to medical education, especially in the Asian Pacific countries, and he makes frequent visits overseas every year to all these countries and in the region, and he offers teaching in terms of gynecological oncology, endoscopy, women's health, as well as hospital administration. With that, I would like to invite Professor Felix to take over the floor. Thanks.
Thank you, Dr. Chua. And
thanks.
Where's the next? Next, please. Yeah. So sorry that I'm dressing very casual. And can I have the next slide, please? How can we turn the next slide, please? Yeah, thanks. Dr. Kwan is currently in the Mahkota Medical Center in Malaysia. He also served on the hospital board of gynecology. He is a well-trained specialist and consultant in obstetric and gynecology, and was admitted as a fellow of the American College of Surgeons in year 2018. His area of interest and practice are advanced minimally invasive surgery and gynecological oncology. He has been a fellow of the APAGE minimally invasive therapy based in Lincoln, Taiwan, having trained under Professor Chyi-Long and Dr. Kwan Kun Chan. Before that, he underwent fellowship training and diploma training in World Laparoscopic Hospital, New Delhi in India. And his other engagement include being a member of the College of Obstetric and Gynecology, the Academy of Medicine, Malaysia. He is also a subcommittee in the gynae endoscopy for the Obstetric and Gynecological Society in Malaysia. So he's the chairman today. So without further, is there any other thing? We need to introduce then. The next one is Professor Chyi-Long. Can I have the next slide, please? Next. Professor Chyi-Long is going to give us the opening remark. Professor Chyi-Long do not need any introduction because it's well known among us. He's the professor in Chongqing University and also the board chairman and the board of trustee of APAGE. He was offered honorary fellow of the European Society of Gynecological Endoscopy, Chinese Obstetrician and Gynecologist Association, and the Philippine Society of Gynecologic Endoscopy. He specialized in infertility, IVF, malignant tumors, and genital tract malformation. You see, he's all-rounded. So before further ado, I will ask Professor Chyi-Long to give an opening remark. Professor Chyi-Long. Is Professor Chyi-Long around? Juan Kunchen, is Professor Lee around? Yeah, okay. Anyone can help? The video doesn't work.
Multiple topics such as the fibroid, adenomyosis, and the infertility. With everyone's effort, the webinars have successfully conducted. The mission of the HIFU webinar is to promote the non-invasive therapy, endoscopy technique, knowledge, and education. Experts will share their precious experience to the audience all over the world. Changing HIFU is the best in clinical study, the service in the world of the HIFU that keep making further progress. This time, we focus on vulva and cervical lesions, the topics you should never heard before. The webinar will bring together prestigious pioneers to exchange study and knowledge. It is an outstanding opportunity to keep up with the on the latest developing in gynecology. I hope this webinar will be a significant one and with fruitful result. We're looking forward to your participations for next episode on 18th August. Thank you, first one, and Dr. Chua, for your introductions. I think that this meeting will be very meaningful. Welcome you all to this meeting.
It's good to see you, Professor Lee.
Yes, Dr. Chua, Phyllis. Hi.
Yeah.
Yes, thank you.
Hi.
Thank you for your organize and holding this meeting.
Okay. So I guess I'd like to say thanks to Professor Lee for the opening remarks. If there's nothing else to add, I'd like to first move on to our first speaker of the day, who is Professor Lee Chengzi, Professor Lee. And Professor Lee will be speaking on the topic, is focused ultrasound. Sorry, hang on for a minute. Is focused ultrasound therapy a new way to treat high-risk HPV infection and cervical intraepithelial neoplasia? Next slide, please. Next slide, yeah. Okay. So this is just a brief introduction for Professor Lee. She's a professor in the College of Biomedical Engineering in Chongqing Medical University. She's a director of the Research Center for Minimally Invasive and Non-Invasive Treatment of Vulva Diseases in Chongqing as well. Other than that, she's also a committee member of the International Society for Study of Vulvovaginal Disease. Professor Lee has been engaged extensively in research and teaching in Obs and Gynae for the past 35 years. She has devoted herself to the basic and clinical application research of focused ultrasound for vulva and cervical diseases for more than 20 years. And she has also accumulated a vast experience in publication, and namely 16 SCI's papers on journals in obstetrics and gynecology, ultrasound, as well as the American Journal of the Medical Sciences. With that, I would like to invite Professor Lee to deliver her first lecture. Thank you, Professor Lee. The floor is yours.
Okay. Thanks, Chairman, to the introduction.
正在录制该会议。
Good evening, ladies and gentlemen. My topic is about is focused ultrasound therapy, a new way to treat high-risk HPV infection and the CIN. At first, we talk about principles of focused ultrasound therapy in HR-HPV infection and CIN. Global strategy to eliminate cervical cancer. Global strategy to accelerate the elimination of cervical cancer as a public health problem. CIN is a prevalent condition of cervical cancer. Cervical HPV has been found in up to 99.7% of cervical cancer and is implicated as a conceptual agent for CIN development. Terminal treatment of CIN is necessary to avoid its progressing into invasive cervical cancer. This table shows classification and evaluation of cervical squamous interepithelial lesion WHO classification. Treatment for CIN include expectant management and surgical treatment. Women with no-cell biopsy proving CIN1 and satisfactory colposcopy should be followed by cervical cytology screen. For women with high-cell cytology who had histology diagnosis of CIN1, most guidelines recommend a diagnostic excision. ACCP recommends that women with histological diagnosis of CIN2 or 3 should undergo ablation or resection treatment. Treatments for CIN and HIV/HPV infection, such as cryotherapy, laser ablation, and surgical excision, are all invasive methods that may cause invasive infection. These include bleeding, infection, stenosis of the cervix, and even severe complications in subsequent pregnancies, including protein loss, abortion, protein birth, and low birth weight. Though it's important to find a larger infection alternative and relatively non-invasive method to treat CIN and persist high-risk HPVs. Ideally, result compromising the patient's pregnancy. Focused ultrasound is a new and promising approach in clinical practice. Pfizer clinical studies had shown that focused ultrasound therapy as a non-invasive treatment for CIN and HIV/HPV infection was feasible and effective. The duration of vaginal discharge after treatment and wound healing was short. This video shows the principles of focused ultrasound therapy. The chronic beam passes through the human epidermis or vertical mucous membrane and focused at 3 to 6 millimeters under the skin and the mucosal membrane. Focused ultrasound treatment generates high effect clinical effects and cavitation effect that nature the disease diffuses and facilitate the local cysts and the local necrotical fuses being replaced over time by surrounding normal health fuses. Focused injury leads to the thermal destruction of the target fuses at deep pace without damage to surrounding or overlaying fuses. There are many differences between focused ultrasound therapy, the traditional invasive surgical treatment. Ultrasound engineer can directly focus on the basic laser of the epithelium through the superficial epithelial tissues, as the HPV invests the human epithelium with the basal DNA replacing in the baseline cells. It's speculated that focused ultrasound can destroy HPV virus, particularly smetoros, destroy the basal cells. Inflammatory cells and the diseased tissues are far more sensitive to focused ultrasound engineering than normal tissues. Therefore, the diseased tissues can be destroyed, while the normal tissues can keep intact. Focused ultrasound can enhance the body's and help to clean the HPV virus and help the disease tissues. Here are the characteristics of focused ultrasound therapy. Short focal lesion, non-invasive and accurate stages. Using educated complaint building, real-time monitor and does adjustment. Virus automate the clinical particulars and daily standards. No smoking, light or lighting, radiation contamination. Repeatable treatment. There are the indicators for focused ultrasound therapy. Chronic subsidies with clinical symptoms and with or without HPV infection. Persist CN1 or CN1 with clinical symptoms. Biopsy confirmed CN2 or 3 with satisfactory colposcopy, especially young women with fertility equipment. Focused ultrasound is only used for patients with satisfactory colposcopy, no tumor indicated by PCT or colposcopy, and ECC longitudinal. There are the contraindications for focused ultrasound therapy. Patients in menstruation period, patients in pregnancy and lactation, acute infection of the disease lesion, cervical cancer, and ductal carcinoma. There is a lesion in the cervical corner, uncontrolled diabetes, severe cardiopulmonary palliative and liver dysfunction. Preparation before treatment. Cervical paper PCT test to exclude patients with cervical malignant disease. Pelvic examination to exclude patients with acute or subacute inflammation of a genital tract. Vaginal discharge smear to exclude the patients with tracheostomy vaginal test and fungal infection. Patients should not receive other therapies within 3 months. How to carry out the focused ultrasound therapy? First, treatments were performed on days 3 to 10 after menstruation. Second, laser anesthesia, no analgesia was required. 3. After the sterile speculum was placed in the vagina to expose the cervix completely. 4. The cervix was completed and covered with ultrasound component before treatment. The 5. The treatment probe was applied in close contact over the tizzy and the CNVZ of the cervix. The 6 is moved continuously at the span of about 5 to 10 millimeters every second in a circular fashion against both the disease area in the tizzy and an addition 2 millimeters of health tissues around the treated area. The requirement time was about 120 or 300 seconds. This is the criteria of the session, the treatment. After treatment, the treated area should cervix has glass white appearance about not to have been damaged and diluted. The cervical lesion has been contracted. The central cervical area has been retracted slightly. The second, we talk about the application of focused ultrasound in HPV infection and the CIN. This table shows the clinical observation of focused ultrasound therapy for cervical disease in some hospitals. We can see the total infectable rate is about 98.7%. This is a clinical observation of focused ultrasound therapy for cervical disease conducted by Southwest Hospital. The current rate of CN1 with one treatment session is about 87.78%. This is an outcome study of ultrasound therapy for CN1. The conclusion for CN1 indicated for intervention. HIFU has the advantage of causing low hard scar in local cervix and can promote the service of lesion, reduce the resistance rate of lesions and prevent the further development of cancerous lesions. These studies infections focus ultrasound on progenies outcomes in patients with CN1 or 2. Conclusion: focused ultrasound therapy is a safer and effective method for the treatment CN1 or 2. It has no significant effect on the diagnosis and outcome of the patient, and does not increase the incidence of premature delivery and low birth weight babies. This table shows clinical effect of focused ultrasound therapy on no-cell statistics of effects of focused ultrasound therapy in 2009 to 2020 publishing the lecture. There were more than 6,000 cases of HPV infection and no-cell, with an average cure rate of 85%. Comparison of focused therapy with other methods. It's safer, effective, non-invasive, non-radioactive, and controllable for the treatment of cervical HPV present infected lesions. Comparison between focused ultrasound and laser therapy. Cure rate and the effective rate of focused ultrasound group and other of laser group were not significant different. Comparison of the side effect in ultrasound group and the laser group. The side effects of ultrasound therapy were significantly lower than those laser therapy. This study shows the efficacy comparison of focused ultrasound and the drug therapy for HPV infection. Focused ultrasound therapy can eliminate HPV infection in a short time, and its therapeutic effect is significantly better than interim drugs. This paper shows a clean rates of HPV with 1 year after focused ultrasound therapy or lipotherapy with HICL under 30. At 12 months of follow-up found that focused ultrasound therapy was upper rise to lipo in the elimination of HPV. At last, we will show the case here. This patient is 28 years old with HPV infection for 1 year. Cervical biopsy, histological diagnosis is no-cell CN1 at 1 point. We gave her focused ultrasound treatment. This is before treatment. This is the infertility after treatment. This is after treatment through months. The cervical recovered to normal. The HPV negative. This patient with cervical HPV 58 infection. Cervical biopsy at 11.71. This before treatment. This after treatment 3 months. The lesion has subsided. PCT and HPV turned negative. This patient is only 21 years old. PCT examination, no cell. HPV testing HPA60 positive. Cervical biopsy is chronic cervicitis and focal HSIL CN2 or 3. After focal ultrasound the treatment 3 months. This is before treatment. This is after treatment. There are laparoscopy show complete regress of the lesion. The HPV TCT negative. The biopsy showed chronic inflammation. This patient is only 25 years old. LCT shows no cell. HPV test is positive. The cervical biopsy shows CN2. ECC is active. We give her focused ultrasound therapy. This is before treatment. This is after 3 months treatment. There is no lesion, and LCT and HPV all negative. This is another patient with HPV positive LCT ASCAS high. Pathological biopsy is 013. ECC is negative. She was performed focused ultrasound therapy. After treatment 3, the lesion is disappeared. The HPV and TCT returned negative, and the early pregnancy was diagnosed 10 months after treatment, and the natural birth was delivered in May 2017. The physical examination of LCT and HPV is negative 42 days after delivery. We'll talk about the condition of focused ultrasound on cervical lesion. Satisfactory laparoscopy, cytological colposcopy, and physiological diagnosis were consistent. There is no lesion in the cervical cancer, and the adenocarcinoma were excluded. The lesion does not exclude 17% of the cervical area. Use of focused ultrasound therapy has followed the standardized clinical practice, strictly following the treatment indications. And the advantages of focused ultrasound on cervical cancers: it destroys the basal layers which enable the HPV viruses so as to reduce the persistence of the HPV infection and prevent its further development into cancerous lesions. All inflammatory cells and disease tissues are sensitive to ultraviolet energy. Abnormal cervical tissues are affected by the focused ultrasound therapy. There is no scope for necrosis after treatment. It also reduces the physiological and economical factors of the patients. It is also a pollution-free operation that does not generate odors or smoking or involve burning of tissues or emission of radiation. Summary: focused ultrasound can safely and effectively treat HPV infection and cervical lesions. Focused ultrasound can clear HPV infection in a short period of time and make cervical lesions go away with few adverse reactions and good tolerability. It provides a good choice for patients with a genetic clinical requirement for treatment. The effects of focused ultrasound therapy in treating ISIL and its effect on pregnancy is further clinical observation and multi-center clinical trial.
Thanks so much.
Yeah, thanks, Professor Lee, for the very enlightening and informative presentation. I believe we have one question from the floor. So basically the question is like this, Professor Lee, from Dr. Ina, I believe. what kind of medical therapy do you provide to patients with high-risk HPV infection in your practice?
Kind of. We use focus ultrasound in short trigger.
I see. So, like, do you provide anything other than the focused ultrasound therapy, Professor Lee, in your practice for these kind of patients with high-risk HPV? Professor Lee, can you hear me?
Hi.
Yeah, can you hear my question?
Yeah.
Yeah. So the question is, I mean, we know that you use this focused ultrasound therapy for patients with cervical diseases, but do you give medical therapy, you know, like drugs or other kinds of treatment other than your focused ultrasound in your practice?
Dear colleagues, dear professor, my questions is about medical treatment, because in Russia we have one registration remedy. It's called D-indolylmethan. It's vaginal or rectal suppository, and we use when we have cervical intraepithelial neoplasia 1 degree, we use this remedy. But if we have CIN2 and more, we perform destruction of cervix and additional medical treatment, D-indolylmethan.
I'm so sorry. I'm so sorry.
It's okay, Professor Lee. Yeah. So I believe Dr. Ina's question was any medical therapy, correct? Other than this focused ultrasound. Yeah. So like Professor Lee, do you have any other, you know, treatment options like what the audience have asked, or it's just focused ultrasound only? Okay, never mind. I think maybe Professor, yeah, like Professor Lee can get back to the question later. I'll just Professor Felix would like to answer. Yeah.
Yes, I know in China,
Yeah.
they also use quite a lot of interferon, and they said the result is around 70 to 80% effective in patients who have HPV infection. So that's what my understanding of some of the medical treatment they have used.
Yeah. So I hope that answers the question. Now the next question would be like, Professor Lee, can the lesions caused by HPV in the vagina be treated with the focused ultrasound as well? So we'd like to answer this.
На влагалище. Он только поделился на то на шейку воздействие, а он на влагалище. Айна, а можете принести насадку на шейку нашу? Насадку от чего?
Or maybe Professor Felix, you would like to answer this? Like HPV in the vagina, can it be treated?
The vagina, depending on the, because the direction of the vaginal probe, you can see it's easier to touch the cervix, run and run, and it's also a few millimeter depth to the destruction. So for the vagina, sometimes can be difficult, especially for someone who is very atrophic vagina, and also when the vagina, the lesion is and a fornix at a corner. Sometimes you may not be able to touch the surface evenly, so it will be difficult. When we compare with we are using laser or diaphragm, I mean, it's much easier to operate in our traditional way.
Okay, thanks, Professor Felix. Now, because of time constraint, I'll just pass on another question, the last question. That Professor Lee, like, what are the precautions that you will take for patients after the focus ultrasound session? Or maybe Professor Felix and Professor Lee can answer together. Yeah. Is there any precautions to take after the treatment session for patients?
Yeah, I've tried to use, I must say, I've used this machine and also have written a paper with Professor Lee. And from my understanding, the treatment is really non-invasive. There's no bleeding at all. The only thing is occasionally some patient may have and may have to give patient antibiotics.
I see. So that is a very good point, Professor Felix. So like usually, like what kind of antibiotics do you use for cover after the procedure?
I usually just use the Augmentin, or one of the also infection gram-negative. I use fragile. That's metronidazole, and to treat the patient postoperatively, just for 3 to 5 days.
Yeah, that is actually a good choice, Professor Felix, because then you'll be covering the anaerobes as well as the other organisms in the vagina. So that is a very good precaution. So I mean, that is all a very good session, and thanks to Professor Lee and Professor Felix for the Q&A session. Without delay again, I would like to invite Professor Felix to introduce the next speaker. Professor Felix, the floor is yours.
Yeah. Next speaker will be a talk by 2 doctors, Professor Apolikina Anna and also Dr. Catalina Tatiana. I'm sorry I may not be able to pronounce the name correctly. I just use my English pronunciation. So if there's any terrible pronunciation, I'm sorry for that. Now, Professor Apolikina is a professor from National Natural Medical Research Center for Obstetric and Gynecology and Perinatology, named after Academia V.I. Kulako of Ministry, also a member of the Academic and Dissertation Council of Research Center. Also a member of International Urogynecological Association and European Urogynecology Association. She was awarded by the Certificate of Honor of Ministry of Health of Russian Federation in recognition of her service in healthcare and long dedicated work. Now, this other speaker, next, please. Next slide. Yeah, and Dr. Tatiana is a gynecology in emphatic gynecology and rehabilitation department, National Medical Research Center for Obstetric and Gynecology and Perinatology. The same institute, Professor Apollina, and she is now providing the gynecological and urological medical service for women from all over Russia. Development of scientific basis for gynecological and urological science and testing of new medical treatment technique and equipment, adoption of new operating technique. So they both will be jointly talk about the HIFU treatment for non-epithelial neoplastic epithelial disorder of the vulva. Yeah. May I have Professor Apollina for the talk, please?
Good afternoon, dear Chairman, dear colleagues. My name is Inna Apolikina. I am Head of Aesthetic Gynecology and Rehabilitation Department at the National Research Center for Obstetrics, Gynecology and Perinatology, Moscow, Russia. First of all, I would like to thank the organizers for this opportunity to take part in this webinar and share our experience. It's my conflict of interest disclosure. The equipment CZF ultrasound therapy system was kindly provided by distributor Grant Medical Company. Now I would like to say some words about our research center. Our research center incorporates institutes of obstetrics, gynecology, perinatology, oncogynecology, mammology, pharmacology, and reproductive medicine. There are also over 20 laboratories carrying out research work. Now I would like to take a few minutes of your attention to describe our department and its activity. The Department of Aesthetic Gynecology and Rehabilitation was first opened in Russia in 2016. Today it's a multi-functional department that uses all the innovative technologies of diagnostics and treatment, gynecological diseases, and for 6 years we have been training doctors, conducting scientific research and providing medical care for women with various gynecological diseases and aesthetic problems. Association of Aesthetic Gynecology Specialists in Russia was set up in 2017, and today's its membership is more than 1,200 doctors. The first International Congress on Aesthetic Gynecology and Anti-Age Medicine that took place in Moscow in April 2022 serves as evident proof of our growing cooperation with research communities from other countries, includes China. We have two possibilities to use HIFU in gynecology. It's lifting the perineal tissue and vaginal walls, non-registered for gynecology in Russia, and generative diseases of the vulva, vagina, and cervix since 2019 here in our center. Today I am going to speak about treatment of non-neoplastic epithelial disorders of the vulva with HIFU technology. In recent years, we observed the incidence increased of lichen sclerosus increased in women. And recent years, we observed that lichen sclerosus affect younger women. And in case of squamosous cell carcinoma of the vulva, the risk increased by 5%. According to the data of our department, over 2014 to 2019 years, the incidence of lichen sclerosus among other vulvar disorders was 63%. In our department, before HIFU treatment, a complex method of treating patients with lichen sclerosus used exposure to a fractional CO2 laser, alternative with the introduction of platelet-rich plasma in the interval of 3 to 5 weeks twice. Combination therapy was most effective in patients with dyspareunia and dryness, while local glucocorticosteroids with itching in the vulva. This slide presents the results of treatment of patients with lichen sclerosus. We use fractional CO2 laser, DECA, in the mode of monotherapy and in combination with platelet-rich plasma. The period of remission of lichen sclerosus was up to 3.5 years. And now let me share our experience in using HIFU technology in treatment of non-neoplastic epithelial disorders of the vulva. We use a special nozzle to treat the vulva. Before HIFU treatment, usually we perform effective local injection anesthesia with 1% of lidocaine. That is how we perform the HIFU procedure on the vulva. And after effective anesthesia, it's pretty comfortable for the patients, and she only can feel mild warming. And you can see in the picture our procedure. Our observational study included 103 women with lichen sclerosus and hyperkeratosis. We performed 1 or 2 HIFU sessions, and follow-up period was on 3, 6, and 12 months after. We diagnosed vulvar disorders by means of visual examination, valvoscopy, optical coherent tomography, ultrasound diagnostic, microbiome of vulva, HPV PCR, fluorescence diagnostics, and of course punch biopsy. The diagnoses were verified by punch biopsy and histological examination, and we know indications. Indications are tumor verification and its exclusion, inefficient therapy, differential diagnosis with vulvar intraepithelial neoplasia, lichen planus, and other dermatosis of the vulva. For effective visualization of neoplasm, threads, and fillers, we use high-frequency ultrasound of the vulva. We use 12 to 23 Hz, which allow us to examine superficial structures. The slide shows a possibility of ultrasound diagnostics in the assessment of blood supply and even elastography. We actively use a mobile colposcope, EVA, which allows effective early diagnostics of vulvar diseases and online consultations. I want to emphasize that it's very important to diagnose vulvar. There, 3-degree extramammary Paget's cancer and melanoma of vulva, while women came to me only with a complaint of vulva itching. Extramammary Paget's cancer is a rare type of genital cancer. Usually it's treated by vulvectomy, but fluorescence diagnostics allows to determine the exact border of the tumor, thereby reducing the resected tissue amount during surgery. Since 2022, in cooperation with Russian physicists from other regions, Nizhny Novgorod, we have started development of a new method of multimodal optical coherent tomography for the diagnostics of lichen sclerosus. Optical coherent tomography is an emerging tool for non-invasive visualization of the tissues with high resolutions up to several micrometers and penetrations depths up to 2 millimeters. This method correlated well with histological examination. We can assess dynamics of changes of diseases of vulva. In a study of the vulvar microbiome in patients with lichen sclerosus, the prevalence of Lactobacillus gasseri was 44% compared with 9% in healthy women. We agree with authors of a recent systematic review that lactobacillus gasseri dominated as at vestibular dynia and significantly correlated with burning and pain intensity and dyspareunia severity. So, I would like to show you several clinical cases. The clinical cases number 1. You can see patients 68 years old with lichen sclerosus and genital urinary syndrome of menopause. She was treated with 2 HIFU sessions and estriol cream, 0.5 milligram per vagina twice a week. Follow-up period was 14 months, and then symptoms of cracking returned and patient started platelet-rich plasma and topical glucocorticosteroids because of COVID-19 pandemic limitations. These patients improved symptoms and she satisfied from treatment, but she had cracks in posterior commissure, as you can see on the last picture. In this picture, you can see patients 42 years with lichen sclerosus and stress urinary incontinence. She was treated with 1 HIFU session. Follow-up period was 6 months. Then symptoms, itching and burning returned and patient started platelet-rich plasma and topical glucocorticosteroids. This clinical case demonstrated efficacy of HIFU is limited 2 to 3 months, and HIFU technology has no effect on stress urinary incontinence. This older patient, she is 73 years old. She has lichen sclerosus and genital urinary syndrome of menopause. She was treated with 2 HIFU sessions. Follow-up period was 6 months. Then symptoms, itching and burning returned, and patient started platelet-rich plasma and topical glucocorticosteroids. This case shows insufficient HIFU effect because we suppose that of age 73 years patients and severe hyperkeratosis. This slide shows us the younger woman, 36 years, with lichen sclerosus. She was treated with 1 HIFU session. We observed reducing the main symptoms of lichen sclerosus. It's, of course, itching. Follow-up period is 12 months. Patient is under observation now. In this picture, you can see patients 42 years old with lichen sclerosus. She was treated with 2 HIFU sessions and estriol cream 0.5 milligrams per vagina twice a week. Follow-up period was 1.5 years. Then symptoms of burning and cracking returned and patient started platelet-rich plasma and topical glucocorticosteroids. In this picture, you can see a woman, 39 years, with lichen sclerosus. She was treated with 2 HIFU sessions and 3 sessions of autological platelet-rich plasma. All symptoms disappeared, but visual changes seemed insufficient. Follow-up period was 12 months. Patient started topical glucocorticosteroids. We consider that HIFU in combination with glucocorticosteroids are more effective in case of severe hyperkeratosis. This is a very interesting clinical case, number 7. You can see patients 40 years old with lichen sclerosus and vulva synechia. We performed treatment with estriol cream, mometazone cream, glucocorticosteroids when severe itching, and HIFU 1 session. We provided a synechia resection with surgical CO2 laser. I would like to show our resection of synechia of vulva with fractional CO2 laser DECA. It's synechia with successful resection with CO2 laser. Okay. This slide shows successful cure of the patients 39 years with vulvar intraepithelial neoplasia, mild degree after 2 sessions of HIFU and 3 months interval. She had no visual signs of vulvar intraepithelial neoplasia, but after 2 sessions of HIFU, we observed disappeared of itching and according histological examination, complete cure. The very important question is what is the optimal interval between HIFU sessions? These patients treated with 2 HIFU sessions. She is 48 years old with lichen sclerosus. This therapy was in monotherapy with interval 6 months, and we conclude that it's very long time between sessions and diseases activate again. Nowadays, we provide 3rd sessions and added glucocorticosteroids. Our data shows that HIFU is more effective in young and premenopausal women. 71% of patients noted the absence of itching and burning 1 to 3 days after procedure. The optimal course is 2 sessions and interval between 1 to 2 procedures in 3 months. High efficacy when we combined with PRP and hyaluronic acid. In 2 patients, adverse events were reported. And I would like to show you our complications of HIFU procedure. In our observation study, only 2 patients showed local skin burns. We presume that these complications could be caused by a defect in the lens. Patients were successfully treated with regenerative local ointment and physiotherapy. We use low energy laser, phototherapy, and etc. And you can see our patients with complications of HIFU procedure. In conclusions, I would like to say it's very necessary to prepare the mucus of vulva for the HIFU exposure. Equipment setup should be carried out together with manufacturer, and turning parameters carefully calibrated and written on the standard operation procedure. In conclusion, I would like to say that HIFU therapy advantages are that it's minimally invasive precision outpatient procedure, it's repeated with no limitations, high efficacy with low adverse, and we need to need further randomized clinical trials, investigator. At the same time, there are questions worth discussing. Is it possible to increase the time of exposure up to 40 minutes? The second question is, can it be justified for use on children and adolescents? Third questions, possibility to treat vulva intraepithelial neoplasia 3 and higher parameters. 4 questions, possibility of using HIFU for vulvodynia, and the upgrade equipment is being available. We are ready to put in practice. What are the advantages and benefits of this new equipment? I would like to say that since 2019, our institute actively collaborates with China researchers. We have several topics in our cooperation. It's introduction of direct mass spectrometry methods into clinical practice in China. We have 2 grants: study of the mechanism of metastasis of sentinel lymph nodes in breast cancer from molecular profile to express diagnostics, development of the method of the differential diagnosis of ovarian masses using high resolution mass spectrometry. And since 2022 years, organization of a training center and a distance consultation center for ultrasound diagnostics with Beijing Hospital. And I hope that our cooperation with HIFU technology will continue and could be published in our joint reports.
Well,
Thank you for your attention.
yeah, thank you, Anna, for your wonderful lectures. And it's very good because these are the treatment not commonly seen in Western country, only in China and also in Russia, possibly, because we don't have the machine that are doing the job at HIFU treatment for the vulva. So I would like to say, are there any questions from the floor people want to raise? Maybe I will follow up with one of the questions. Is that are you treating your patient at day-only surgery, or they are in the hospital after the HIFU treatment to the vulva? And what are the postoperative care you are going to give to your patient? Can you highlight about this answer?
Dear Professor, could you repeat, please, your questions, because we didn't hear, because it's a little noisy. Okay. Could you repeat, please?
Are you treating your patient in the hospital at day-only surgery? That means they go home after the treatment. Or are they going to stay in the hospital for a few days? Secondly, what are the postoperative treatment you are going to offer to your patient, because it can be very painful and edematous. So can you elaborate the answer?
Yes. The first question about outpatients procedure. I absolutely agree with you, because its procedure is absolutely ambulatory procedure, outpatients procedure.
Right.
We doesn't need to hospitalization our patients in hospital. We have a lot of department, one-day clinic, hospital, but we performed only in ambulatory procedure. It's absolutely outpatients procedure.
Okay.
После операции. According our experience, the condition after HIFU procedure is absolutely painful. Our patients didn't complain about pain.
It's very good of them, because our patient in a Western country always complain of pain. So you're lucky. Are you giving them local anesthesia to release the pain at the treatment?
Yes, of course. Before procedure, we used special anesthesia with 1% of lidocaine. It's enough for anesthesia. Yes, local anesthesia. And the main questions for us now is the maximum period of exposure, HIFU exposure. I think we may increase time of exposure, because now we use only 10 minutes, maximum 15 minutes. But in my opinion, I think we may increase our time until 20, 30 or 4 minutes. Do you agree with me?
Okay, Thank you.
Мгм.
Dr. Kwok, your turn.
С кем можно контактировать?
Hi. Okay.
Нет.
So, like,
Ладно,
I
это
guess, I mean, just now, Dr. Felix, would you like to answer the last question by Dr. Ina about the time of exposure?
Hmm.
Вот. Мгм.
Well, I have no experience, and possibly maybe Dr. Lee from China will be able to answer the question. She's also the expert for this treatment.
I see, I see. So I guess in the interest of keeping time, we will just go ahead and maybe the questions can be emailed later, or if you have any questions, just get in touch with the secretariat. So without, delaying again, I would like to invite our next speaker, Dr. Kwan Ken Huang, for his lecture on HPV vaccine beyond cervical cancer. And before that, I would like to make a short introduction of Dr. Huang. So Professor Huang is a very well-known academician. He has trained a lot of minimally invasive gynecologic surgeons, and probably he has lost count. That is how many he has trained. And he's very influential in that regard. He is currently the executive director for the TAMIC, which is the Taiwan Association of Minimally Invasive Gynecology. He is also the chairperson of the Changgung Memorial Hospital International Fellowship Training Program in Minimally Invasive Gynecology. And other than that, he's an associate professor of Changgung Medical University in Taiwan. He's also assistant professor of the Department of ONG in the same hospital. And he is also working as the editor of GMIT, which is the official publication of APAGE and a peer-reviewed journal. With that, I would like to invite Dr. Huang to give his lecture.
Thank you. Thank you, Dr. Chua. Yeah, nice to meet you. Yeah, because
yeah, nice to see you.
Hi, everyone. The friend of APAGE and ISMIVS. This is a webinar. It's my great pleasure to present this topic about HPV vaccine and HPV vaccine beyond the cervical cancer. I think I'm an oncologist, and APAGE and ISMIVS is a mini-invasive and non-invasive platform in the world. So I think the HPV vaccine is the most mini-invasive or non-invasive in treatment or prevention of cervical cancer. First, I must introduce the professor, the physician, and scientist. Hao Shen is the Nobel Prize winner in 28. And this year, 28 had three Nobel Prize winner, and Hao Shen win the half of the money, and another two share the left half. The two doctor is the credit is about the discovery of HIV virus, and Hao Shen is because his discovery of human papilloma virus and the cause of cervical cancer. So if you are old enough, you know about cervical cancer, there are many series. What reason causing cervical cancer? But finally, we know that's the human papilloma virus. That's the Hao Shen credit. The discovery of human papilloma virus, so everyone can focus on how to prevent or in the future treat of cervical cancer through the HPV virus. And we now know HPV virus possibly is a sexual transmitted pathogen, especially genotype 16, 18, approximately 80% of cervical cancer. Another type, so-called high-risk HPV type, 31, 33, 45, 52 and 58 cause another 20% of cervical cancer. Also, type 16, 18 is the cause of orophageal cancer, vulva cancer, and the vaginal cancer, and in the male, penile cancer. So that's a very, very great contribution, the discovery of HPV virus. And another not life-threatening, but the quality of life is about the 90% of anal genital warts. Also because of the type 6 and type 11 HPV virus. So now first, we talk about how to prevention of cervical cancer. You know, cervical cancer is preventable because the course of cervical cancer is gradually, very slowly from normal CN1, CN2, and CN3. So any stage we can cure before this disease, and then after become a cervical cancer. Pap smear is in the about 50 years for the prevention of cervical cancer, and have a greater contribution in the prevention of the cancer. But now we call pap smear is a secondary prevention only. Pap smear is decided by a Greek pathologist, but you know the process is a time labor work is not so easy. Every process must be accurate. Otherwise the smear quality is not sure. So sometimes it's false negative. So you must frequently take pap smear. In Taiwan, the female age over 30, every year, the government insurance cover pap smear every 1 year, because they are some false negative. But now we call HPV vaccination is the primary prevention of cervical cancer. Why HPV vaccination is primary prevention? Because now we know cervical cancer comes from CN1, CN2, CN3. It's because persistent HPV infection. So turn the normal epithelium into pathological change from CN2, CN3, then become invasive cervical cancer. This is a WHO life course approach to cervical cancer control. So in the primary prevention, the girl from age 9 to 14 give the HPV vaccination, and women over 30 have a second prevention, always take the pap smear or HPV. Then third prevention is treatment of the microinvasive or carcinoma in situ, treatment of cervical cancer at any age. Their goal is in the 2030, we want to elimination of cervical cancer through the vaccination or pap smear and treatment. The first prevention, second prevention, and the treatment of cervical cancer possible in 2030, we can eliminate the cervical cancer in the world. I think it's possible. and most contribution I think possible comes from HPV vaccination. Today, we must know is about the HPV virus. HPV virus is not only the region, the cause of cervical cancer. It's about 91% cervical cancer is because HPV persistent infection, but also vulva cancer, vaginal cancer, and 69%, 75%. Even in the orophageal cancer, about 72% is the cause of HPV infection, and anal cancer 91%, penile cancer 63%. So because Hausen discovery, so now we know how to prevent cervical cancer by vaccination. So initially, there are two major companies. One is Merck, another is GSK. Merck is an American company. GSK is UK, United England, English from English. So they developed two with the same method, but a different manufacture method. They created the Cervarix, and Merck developed Gardasil series. So there are three major HPV vaccination. About 15 years ago, they developed a very wide clinical trial, and the result is very promising, very good. The quadrate, the 4-title HPV vaccine or 2-title HPV vaccine, that the Cervarix and the Gardasil for prevention CIN2 or CIN2 plus related lesion is almost reaching 100%, even 100%. So the result is very promising, very promising. So now about in the recent 15 years, there are the major three vaccine is Cervarix, that's the 2-title bivalent vaccine. Target is 16 and 18. Gardasil is a quadrivalent vaccine, target 6, 11, 16, and 18. 16 and 18 is for cervical cancer. 6 and 11 type is for warts, anal genital warts. And the next development by Merck company, they developed Gardasil 9, so target 6, 11, 16, 18, and other 31, 33, 45, 52, and 58. So the coverage rate is wider, So in the United States, since the end of 2016, only Gardasil 9 is available. I think because Merck is an American company, I think also scientific reason is enough, because Gardasil 9 is the coverage rate is wider. So in the United States, only Gardasil 9 has been available since the end of 2016. And why we need HPV vaccine, the rationale for female is very clear, because the 18 and 16 type is approximately 70% cervical cancer, and another 20% we also, because of HPV high risk high risk title. And other type also cause about the vaginal cancer, vulva cancer, orophageal cancer. Some is orophageal cancer, about 72%. So HPV vaccine can prevent all the HPV associated cancer. That's the rationale for female. But for male, why you need also HPV vaccine for boys? Because 90% is anal cancer, and some substantial proportion also from the orophageal cancer, penile cancer. But you know, anal cancer and penile cancer is not so prominent, but orophageal cancer is a problem. And 90% HPV, the so-called low-risk type 6, type 11, can cause the anal genital warts. I think that's the rationale for female to give HPV vaccine. But another more important reason is about the herd immunity. Herd immunity. You know, so-called herd immunity in the population must be large enough, be infected or vaccinated. Always the slope is about 70% to 80% cumulative infection. So the R ratio below 1, so there is a herd immunity. How simple to say, the large population enough must be infected or vaccinated. So the other potential risk people can be protected also. So in the reason, even in the cost effective for male vaccination is not so high, but the whole older population is cost effective is higher, especially if the female label of the HPV vaccine coverage is low. And if many countries, the cover rate is below 60%, so you cannot reach the herd immunity. So when you vaccination for both male and female, boys or men and women, is more beneficial for reduce HPV infection and disease. So reach the herd immunity. So that's one of the very important reasons why we must vaccinate the boys and girls at the same time. So there is some recommendation from America Advisory Committee of Immunization Program. So for the national program, there is a route for routine HPV vaccination in the young age for everyone, boy or girl, and the age about 11 to 12, all start from the 9-year-old. That's a routine HPV vaccination. Also, we can have a catch-up vaccination. If you over the age, your age is 13 to 26, also is recommended. That's the so-called catch-up vaccination. And also, like in hospital, healthcare worker, especially for physician, nurse, for healthcare worker, because you have a high risk for exposure to HPV. So even you are older than 26, you are recommended for HPV vaccination. Or if the patient is immunogenic and efficient and safe in the older than 25-year-old. In the United States, I think the Southeast Asia country also the policy is the same. The HPV vaccination is approved through the age of 45, and the age of 45. Even in Taiwan, some patients won't ask HPV vaccination, even the age is about 50, I think that is acceptable also. It can be acceptable also. So the optimal time of HPV vaccination, of course, the most optimal time is HPV naive, because you have no sexual debut. Because always we think HPV is a transsexual infection. So especially in the young age, from 9 to 12, that's the optimal time for HPV vaccination. And some have some reason, because the vaccine is for prevention, not for therapeutic vaccine. But the patient had a history of abnormal pap smear, genital warts, or HPV infection is not a contraindication to HPV immunization, because now HPV vaccine, the most popular is 9 type. So that's rare. You have a 9 kind of HPV infection in your own body. So also there is some protection value. So that's not a contraindication for HPV immunization. The choice of HPV vaccine in the initial phase, there is some debate. Some debate is about the potency, the power of the HPV vaccine. But finally, we think the coverage rate is more important. So the human papillomavirus 9-valent vaccine now always is available. That's the choice. But I think that the cost is higher in many countries, even in Taiwan, the same. But if you are in United States, you have no choice, because only 9-valent vaccine is available. The immunization schedule. So if the girl or boys is young enough, even the clinical trial study, 2 doses enough. But the other population, if your age is over 15 years or older, you must have the normal 3 doses. Or immunocompromised patient, cancer patient, you must have the usual 3 doses of HPV vaccine. Previous have HPV-associated disease also can be recommended in individuals with the recommended age, because that's the reason I said again. The rare have so many kinds of HPV infection in one body, in one person. So you also have some value of protection. So I think that also because the protection efficiency is very high. So also recommended. Also another HPV vaccination recommended is healthcare worker, like our physician nurse, especially for gynecology doctor and the nurse, because we have a high risk to exposure HPV during we treat the patient with warts or the cancer, because some HPV virus can be generated during surgical incision. Yeah, so I think the protection is important. So there is aero digesting nasal or oropharyngeal HPV infection. So I think the must have the idea. We are healthcare worker, the giver. We are high risk HPV infection, not from transsexual exposure, but from our work, because during incision, during operation of the HPV associated region, so protection is also recommended. Because the duration of protection of HPV vaccine is very long. It's very long. It's very long. At least 10 years from the initial HPV vaccination. Yeah, we have a continuous protection. Even in the male, the follow-up about 90.5 years also have a continuous protection. So the value is very high. So the value is very high. So this is my take-home message. We must know HPV-associated cancer is not only cervical cancer. There are many cancers: vaginal cancer, vulva cancer, oropharyngeal cancer, anal cancer, penile cancer. Is a high risk HPV infection. Is also the reason that we call HPV-associated cancer. So for cervical cancer prevention, HPV vaccination is a primary prevention, not a pap smear already. Pap smear is the past. In the past, pap smear is a primary prevention, but nowadays, HPV vaccination is primary prevention. And the HPV vaccination is very effective. Even we can say the most effective. The protection duration can about 10 years. Possible can be longer. And do not like the COVID-19, we must have two boosts and two doses, then boost, then again boost again. Yeah. In the initial study, we know HPV vaccination have the same continuous protection prolonged more than 10 years. And because herd immunity, we suggest HPV vaccination is suitable for female and male, not only for female only. HPV vaccination must be given to female and male. And HPV vaccination is not for cervical cancer only, but for all HPV-associated cancers. Yeah, so the cost effective is very high. So APAGE is want to promote the idea about the mini-invasive treatment or management. So I think the HPV vaccination is the least invasive method to prevent cervical cancer. Thank you, everyone. I think because we have a new idea, especially HPV discovery, so we can develop HPV vaccine. And now we know HPV vaccine is beyond cervical cancer, can prevent vulva cancer, vaginal cancer, oropharyngeal cancer, anal cancer, and anal cancer, penile cancer. And if the immunization must be in the national level, because the coverage rate must be high, so we can get herd immunity. So possible in the future, we can eliminate the cervical cancer or HPV-associated HPV-associated cancer, we can eliminate. Finally, thanks everyone. If you have any question, you can by web through the webinar. Yeah, we can respond to you as soon as possible. Thank you, everyone.
Okay, thanks, Dr. Huang, for the very good update and information provided regarding, the use of HPV vaccination, especially in cervical diseases. Actually, Professor Felix did ask Dr. Huang a question in the chat box, and Dr. Huang has answered. So with that, I would like to ask another question, if Dr. Huang don't mind, just curiosity from my part. Like Dr. Huang, do you normally, what is your opinion about the practice of giving HPV vaccination after excisional treatment for CIN as an adjuvant? Do you think that is a very feasible practice, or you think it is not a good practice? Dr. Huang, we can't hear you. Yeah, now I think we can hear you. Yeah. Okay. Somehow I cannot hear Dr. Huang. Dr. Huang, are you there? There's no sound, right? Professor Felix, I can't hear him.
Yeah, I can't hear. I can't hear either.
Yeah. Okay, never mind. Somehow the sound is not coming. Okay, maybe Dr. Huang can just.
Yeah, Dr. Huang, can you
Yeah.
take your telephone and I call and you answer from telephone? Okay, in English, please. In English, okay.
Okay. Oh, I can speak.
Yes, yes.
Okay. Yeah. In South Korea, there is a very good research. I think not only for other HPV associated issues, but some great so I think actually vaccination, but not also all feedback other HPV associated research. Money, the only coverage cost now is also very high one. So take HPV vaccine. In Taiwan, must cost some about 10,000 New Taiwan dollar. Yeah, but the cost is finally good. I think the HPV vaccine is underestimated. Yeah, that's my opinion.
Yeah. Yeah, thanks, Dr. Huang. So actually, Dr. Apolikina has a question for you as well. Like, if you were given the chance to develop the new HPV vaccine, Dr. Huang, how many types would you, let it? I mean, how many types will it protect from? Like, meaning how many types of HPV, you know, that it will protect against? I think that is the question.
Is cover about 93% CIS already. So for companies, they want to cover more than very high. So I think they do not want to declare. From science point, if you can cover 97%, it's best because 97% the cause of the cervical cancer through the HPV infection. Now nine balance, my kind of protection is about 93% already. So I think not other companies in recent years want to develop. If you want to develop, the American company will develop another machine again. But they do not want that there because they have occupied the market already.
Yeah. Yeah. Thanks, Dr. Huang, for the answer. So I think if there's, is there any other questions from the floor? Professor Lee, Professor Felix, Dr. Apolikina, you know, like maybe Dr. Lee. Actually, Dr. Huang, maybe later you can type in the answer in the chat box because some of our audiences were not able to hear your answer. Maybe a summary will do, Dr. Huang, if you don't mind, yeah, in the chat box. Okay. So, so if there's no further questions, I think maybe we can move on. Yeah. So we are near the end of the presentation. Just bear with me for another few minutes only. So just want to remind everybody that the next APAGE and International Society of Minimally Invasive and Virtual Surgery HIFU session will be on the 18th of August on the same time. So again, at this same time, 18th of August, please stay tuned and join us if you have the time and opportunity. Yeah. And please go on to the next slide. And okay, so this is an announcement about the very interesting training. So basically the third international training workshop on focused ultrasound on therapy for tumors will be held this year, November 12 to 26 in Malacca, Malaysia. Actually, it's in the hospital I'm currently working in. I got to find out recently. So it is a very good training program. It will take place over the span of 2 weeks. And so far since 2012, it has already trained about 149 doctors from 42 different countries. And I know it has been implemented for the past 7 sessions or so. If you are interested to apply for this, please email Hannah at hannah@isminim.org. Send in your resume as well as your curriculum vitae. And only about 20 applications will be accepted after vetting for it. So if you're interested, this is definitely a very good opportunity. And I can tell you Malacca is one of the historical sites in Malaysia. You will have a lot of good food and company waiting for you. So I just would like to say that. Please go on to the next slide. So maybe like our speakers, Dr. Apolikina, Professor Felix, Professor Lee, Professor Huang, Professor Lee Chengzi, can you know, just on your camera for us to take a group photo. Yeah. So I'll leave it to the secretariat to. It's good to see all of you. I hope to see you in Malaysia, especially Professor Lee, Professor Huang, Professor Lee Chengzi, Professor Felix, and Dr. Apolikina. Your presentation was very good. Yeah. So and I mean the photo is already done. The secretariat told me that. And if there's no other issues otherwise, and you know, we will join you for the next session on August 18th. Okay. So Dr. Lee would like to add anything? Yeah.
We want to special thanks to the Dr. Ina from the Russians, and also the Dr. Lee and Dr. Huang to excellent presentation. And also thank you the first one and Dr. Charles, excellent to moderate this session. And welcome you to the next session especially welcome to the APAGE annual meeting in Taiwan in the end of the September. Yeah, I see you there. Okay.
Yeah. So
Thank
Professor
you.
Felix would like to say a few words.
Yeah,
Thank
it's
you very much.
to meet everyone
Thank
here.
you so much.
Thank you very much for invitation, and I hope we will see each other and we will cooperate more close.
Yeah.
Yeah.
Dr. Huang, would you like to say some words? Anything you want to mention? Somehow we cannot hear Dr. Huang. That's very unfortunate. But anyway, Professor Lee Chen-Zhou, would you like to say a few words before we wrap up?
Thank you so much. Thank you,
Yeah,
Professor Huang. Thank you, Professor Lee. Thank you, Professor. Thank you, everybody.
Yeah. Then Dr. Apolikina, anything else you want to add?
I would like to say again, thank you very much for your invitation.
Yeah.
And the topic today was fantastic, and every speaker were brilliant presentation. And I hope in future we will more closer cooperate, and we would like to invite you in Russia, in Moscow, in our institute.
So looking forward to that. Yeah. So thanks everybody. With that, I'd like to say, have a good day and see you again. This is a wrap. Yeah. Bye.
Bye. Bye.
Bye.
Bye. Bye.